We are in live here with Professor Cesar, and I would like to thank you, Cesar, so much for being here with us today. Indeed, you gave us an excellent lecture. Before we start with the audience questions, I would like to remember our colleagues that it's not the first time that you were involved with description of new lesions. I don't know if everybody knows about the history of Professor Cesar, but at 80, Cesar lived in California and worked with Professor Saul Silverman. And at that moment, they described the oral lesions associated to HIV and AIDS. After that, when he came back to Brazil, to São Paulo, he coordinated the oral medicine department of Casa da AIDS with Dr. Davi Wippe. So my friend, I think that you are really brilliant because you always see ahead of the clinical aspect of the lesions. You are always connecting the dots and making the difference. Thank you for your lecture, for your experience, for connect the dots that we have in osteonecrosis. Thank you so much again for being here with us today, Cesar.
Thank you, Manuela. It's a pleasure for me to be here. It's always nice to be far away, but still connected with our friends all over Brazil and all over the world. And I just am speaking English because there are many people attending this session who are English speaking. And so for my Brazilian friends, I'm sorry, but I think my macaronic English is easy to understand. So anyway, it's a pleasure. I just wanted to make a quick explanation. When I was invited by Manuela and Alan and Roger to make this presentation, and I said, well, this presentation I prepared for the American Academy of Oral Medicine meeting that was supposed to have happened in April of 2020. I was awarded a prize. It's the Samuel Charles Miller Award. Samuel Charles Miller was the founder of the American Academy of Oral Medicine. And he was the first person to try to connect oral cavity with systemic diseases and the importance of oral health. So when one is awarded this prize, they request that you present something that is related to your career that you have prepared over the years. And I thought that this would be something significant, especially for the younger people who are watching us, that a simple observation can make a tremendous difference in the lives of our patients and the things we do to care for them. So that's what I tried to do with this presentation. And I think it's a little over 16 years now. When I first saw the cases, actually started in 2000. I was working at Syro-Lebanese Hospital in São Paulo when I first saw the cases, and I had no idea what was going on with the patients. So I just wanted to explain the reason for me presenting this lecture, and I hope you liked it.
Was amazing. Let's go to the chat questions. Dr. Túlio de Lucena Pires, good evening, Professor. It's a great honor to attend your class. At the University of Brasilia, there is an excellent method for managing osteonecrosis with ozone therapy, led by Dr. Sergio Brusadelli. Do you know this therapy? What is your opinion about such therapy?
Well, what I know, I never used it, but I have collaboration with people from different parts of the world. And one group that uses this methodology is the group from Greece. Professor Urania Nicolatougalitis and her team, they develop a paste of ozone, and they always use the paste on a periodic follow-up when they extract teeth, they add the paste in the alveolum, and they claim that they have good results. I don't know of specific studies that have shown the evidence, but the way I tell my colleagues is that if you're doing something that is helping the patients and is not causing any complications, I don't see why not use it. Okay, so that's how I see it. If you have a technique in Brasilia and it's working for you, I commend you, and I would say there is nothing wrong in using it. What I would like to know, perhaps you can tell Manuela, is if you what kind of formulation you use for the ozone.
Great. Another one, Luciano Castro from Federal University of Goiás, UFG, Goiânia. Congratulations, Professor Migliorati, for the brilliant presentation. I have a question about treatment. European work of MRONJ, published in 2019, recommends early surgical treatment even in stage 1 cases. This approach would prevent progression to more advanced stages. Such guideline differs from the American one, since American Academy of Oral Maxillofacial Surgeons indicates conservative treatment for the initial stages and surgery for advanced ones. What is your opinion regarding this controversy?
Thank you for the question. I have seen both worlds. I have seen patients being managed with the we call the medical therapy, where we use clinical hygiene and some topical medications and do the observation and see how the patient responds. And I have seen also patients being treated as soon as they are diagnosed with surgery. Both groups have evidence that it works their way. Some patients may not be ready to go for surgery right away because some of the people being treated with these medications are medically compromised severely. I had patients like that. One case that I remember well was a lady who had a severe case involving molars. And the cardiologist told us that she had a very unstable atrial fibrillation, and that we had to do everything we could to treat her with medications only and topical measures, that she could not resist going to surgery. So every patient is a different case. Groups fight for this. I know the group from Denmark, Copenhagen, that was led by Dr. Morten Schod, who unfortunately passed away recently from a heart complication. His group would treat patients no matter what stage the patient was diagnosed. They would go straight to surgery and try to obtain primary closure. Other groups, like the group in Greece, they treat the patient more like conservatively. In Italy, you have the two sides. And here in the United States, you have also groups that treat patients in different ways. And it depends also who the patient is referred to. If you refer your patient to a surgeon, they're going to do surgery. If you refer the patient to an oral medicine person like me, I'm going to do first my magic. And if it doesn't work, I will work together with my surgeon colleagues.
Another one, Luciana Yamamoto de Almeida. Thank you, Professor Migliorati. Excellent lecture. Do you have any hypothesis to explain why there are no reports of MRONJ related to young patients with osteogenesis imperfecta?
Well, actually, there are people using medications for any disease that has bone involvement. I don't know why some groups will not develop osteonecrosis, although they are treated with a high dose of medications. Children, for instance, who are treated with the high dose corticosteroids develop joint necrosis, and they're treated with bisphosphonates to heal the necrosis. So the situation for children is still unknown, why they do not develop this condition that is more common in adults. I think you saw the last case that I presented. That was a case from Dr. Andrea Caroli, Dr. Alan Roger, and Dr. Fabio Alves and colleagues. They gave me permission to show that case that has been submitted for publication now, which is describes a young girl with giant cell lesions who at one point was treated with a bisphosphonate, and she ended up developing the complication. So that's why we're trying to publish this, because it's rare to have cases in children. So we're still learning. You see that all the time you have new populations being treated with the medications, and then you observe them, how they develop, how they respond to therapy. But to tell you why osteogenesis imperfecta, no cases, I don't know.
Question from Lauren Schuch. Thanks a lot for Professor Migliorati. Your lecture was wonderful. I would like to know your experience with serum CTX as a guide marker in cases that need surgical intervention.
This is an old controversy that we have been dealing with for many years now. And I don't believe that you can use this as an indicator of how your procedure is going to resolve. I never recommend anybody telling patients, we're going to do this test, and depending on the test results, your prognosis will be good or bad. So we do not have science behind it. This came from work done by my colleague, Dr. Robert Marks in Miami. He studied a few patients, and he came with this theory that depending on the level of CTX, you can have a good prognosis or not. We followed patients who we extracted teeth, and we did the CTX test before the extraction and followed them for a long period to see what type of outcome we had. This was published in the Journal of the American Dental Association. And we had patients with a CTX that was very, very high or very, very low. And the result did not alter the outcome of the extraction and the healing. The only thing we have been able to show is that bisphosphonates can delay the healing, but there is no relationship that we see with the results of the CTX test. So here in Florida, where I live and practice, because of the guidelines set up by Dr. Bob Marks, my colleagues, surgeons, have to do it. Because if they don't do, and there is an outcome that is unexpected, they may have to respond in the court of law why they did not follow the guidelines here in Florida. But the guidelines have no support, scientifically speaking. Okay, so if you want to use it, fine, but never make your decision on how the patient is going to respond based on the CTX test.
Another question, Bruna Barcelos Só. Good evening, Professor Migliorati. Thank you for sharing your remarkable knowledge and experience with us. Is there a reason raloxifene not present in the list of medications related to osteonecrosis of jaws you presented? I believe I have read a few cases report on that.
I am not familiar with those reports. I really don't know what the reason would be, but I would love to have a copy of those reports so I can reply to you. If you send it my way, at the end of my lecture, there is my email. I'll be more than happy to discuss the literature with you and provide you with my experience. I have no cases in my experience or colleagues who I collaborate with around the world of patients using raloxifene and developing osteonecrosis of the jaw.
Thank you, Cesar. Túlio de Lucena Pires, one more question. There is a discussion about the onset of osteonecrosis triggered by bacterial contamination. What is your opinion about this disease onset mechanism?
Well, today we firmly believe that the presence of disease is very important in the onset of osteonecrosis of the jaw. I think the group from UCLA, Dr. Sotiris Tetradis and his group have published showing the importance of periodontal disease, of endodontic apical lesions, and they were able to form osteonecrosis in animals, and because of the infection and the use of the bisphosphonates. Now, we have been discussing this in the literature from the beginning. People always claim that dental extractions are the cause of osteonecrosis of the jaw. But you can read the papers and no one tells you why the teeth were extracted in the first place. And I always tell people you have to extract a tooth because of a reason, okay? And usually that reason is because there is infection, the tooth lost the periodontal support, so you have active infection, and that's why you extract the teeth. So we just published a paper together with a group from Greece where we extracted teeth of cancer patients who were referred to the University of Athens for management. And what my colleagues did, they would collect a sample of the alveolum after the extraction. And they were able to show that in many of the cases, there was already osteonecrosis in the alveolum. And that was the reason why the tooth was symptomatic, had no more periodontal support, and had to be extracted. So I believe the presence of microorganisms is a very important finding, because when you have infection, your system, your body has to react to it. But in a compromised system where the bone cannot heal due to the effect of the medications, the infection can overcome the healing system and develop the osteonecrosis. So I believe it's a multifactorial disease, and one of the main players is local infection.
From Vivian Peterson Wagner, but before I would like to thank you, Vivi, for helping me with the questions of the chat. Vivian is sending me all the questions from the chat, but now is her question. Do you believe that advances in medical dental research can lead to more effective drug-based therapy for established cases, prevent new ones, that could act directly on the pathogenesis of osteonecrosis of the jaws?
Well, I don't know of any specific studies right now. They're being conducted with that objective. What we see is that there, like I showed you, everything started with the bisphosphonates, but now there are a number of medications that can lead to osteonecrosis of the jaw. And so I think right now, I don't know of any drug studies that are being developed that would prevent or treat the osteonecrosis effectively. So what I recommend is that we follow our patients closely, take good histories, Sometimes we have to dig down, dig deep to collect information from our patients. Some of these medications, for instance, for osteoporosis, are applied only once a year or every 6 months. And patients don't remember that because they're not using the medication every day. So if you don't ask the right questions, they may not tell you that they're taking the medication. So when they have a problem, you miss the boat because you could have already used preventative measures with the hygiene, close follow-up, patient education, and so on. So right now, what we have that is effective is good histories, early diagnosis, and treatment as soon as possible. And the type of treatment depending on your philosophy and the center where you work at.
Cesar, sometimes we ask to the patients, are you using some medication? No, just calcium. And so show me what calcium are you taking? And when we can observe, they are using bisphosphonates. So
Yes.
for the patient's calcium.
Yeah.
Okay, another one from Reidson Alcides de Lima Souza. Thank you for the excellent lecture, Professor Migliorati. We know that the patient's knowledge of MRONJ is very low. Do you think this is more associated with the communication failures, lack of interest of professionals to correctly guide patients, or even lack of knowledge of the professionals themselves on the potential risks of these drugs?
Yeah, that's a very interesting question because it does it relates not just to dentistry but also to medicine. We in dentistry do not prescribe these medications. They are prescribed by the medical colleagues. So we did a study. We followed patients in our institution who came in for treatment and who were being medicated with one of the bisphosphonates at the time. And we surveyed the patients to find out how much they knew about the medication, what kind of information they had been given by the prescribing doctor, how long they had been taking the medication, and how long they were going to continue taking the medication. And it was staggering to see how little the patients knew about the medications they were taking. And you think, God, you're taking medications, drugs, you have no idea what they are, you have no idea why you're taking them. So, when was the last time you had a bone density test? Oh, I don't know. But you didn't ask your doctor if the medication is improving your bone composition. How long do you have to take it? And so that showed us that it's a big dilemma because we know that if the patient is taking one of these drugs, it becomes our duty, our obligation to talk to the patient about the drugs, what they do, and the risks that they offer when we're doing invasive dental treatment for them. And when we do that, some patients get upset. They may discontinue the medication without talking to their doctors, or they may go to the doctor and complain. That creates a conflict between the dentist and the physician. So it is a very, very delicate situation. But I believe that because the risk is so low that the physicians are not concerned about this. They really don't think about this as a side effect that is significant, and many times they don't talk about it with the patients because they think it's irrelevant and that is more important for them to control bone loss in osteoporosis or to control the pain caused by bone metastasis in cancer and so on. So I do my job. If I have a patient on a medication, I educate them. Pardon me, I talk to them about the side effects that are possible and what we can do to prevent them. And I make it clear that they should never discontinue the medication because I told them these things, that they have to talk to the physician and we can together come up with a decision. Many times when you reach out to the physician and tell them, doctor, you're prescribing this drug for 6-7 years. Do you want to continue? This is still indicated. And it's common when they say, no, we can stop it, no problem. But depends on the situation. They know what the medical status of the patient is. We don't. We know the health of the oral cavity. So we have to be very careful. The information is usually not given to the patients by the physicians the same way we do. I hope I answered the question.
Of course. Following the same line, Dr. Leticia Lang, first of all, she said that she loves your talk, and she would like to know what is your opinion about the drug holidays? What is your recommendation? What do you follow?
Well, there is not much science to tell us one way or the other. We have some studies showing that patients who discontinue the medication may heal quicker than those who continue taking the medication. But this does not apply to all medications, because if you're thinking about bisphosphonates incorporate in the bone matrix. And even when you discontinue the medication, they may remain active for many, many years. Meaning that when you manipulate the skeleton, you will release the medication in the medium, and the medication can inhibit the healing. Okay, when you're using the denosumab will not, or the IV infusion, they will not incorporate in the bone matrix. They are eliminated very quickly, and so the healing effect will be different. Okay, so this is something that is very important to consider. Now, being able to say that you do what the surgeons recommend, you do 3 months holiday before you do the extraction. If you want to do that, do it together with the physician. Okay, don't make the patient stop taking the medication because of your recommendation. Talk to the physician. The physician may know what the risk for that patient to have a fracture or the status of bone metastases, or whatever reason they're being prescribed the medication. So if you want to do it, fine. The rationale is that you will not have constant active medication being given to the system, and that may give you a window of opportunity to do the surgical procedure, and then you reinstate the medication. So this is basically my opinion, my personal opinion. I usually do not recommend stopping the medication unless I talk to the physician and the physician tells me there is no problem. We can do this for a while, do your treatment, and then we can reconsider giving the medication again. Now, there are situations of emergency when there is no time to do that. Patients who are going to bone marrow transplantation, for instance, you have to eliminate disease as much as you can. There are emergencies. Patients come in with dental abscesses. They need to be treated immediately. There is no time to discontinue the medication and then wait. I am of the philosophy that I don't send patients home with active disease because I don't want to treat them. Okay, I prefer to educate them, explain what the risks are, treat them, and send them home without infection.
Túlio de Lucena Pires, what explanation for the paradoxical relationship between inhibiting bone resorption and not repairing bone wounds, given that the medication would only act on osteoclasts?
Well, the medication does not act on osteoclasts only. The medication affects the entire system. It's more effective on the osteoclasts. Now, Amgen developed a new medication called romosozumab, Evista. The name, the brand name escapes me, but it's romosozumab, and romosozumab acts exactly the opposite of the bisphosphonates. Okay, and so bisphosphonates inhibit bone remodeling. Romosozumab stimulates bone formation, and we are following cases during the trials that Amgen is doing, and we have cases of osteonecrosis developed in patients taking the medication that is supposed to form bone. And so we're still learning about this. The medications involve the immune system, involves so many areas in the system that we're still learning. It's a multifactorial situation, and it's hard to understand how much it is that if you block one area of the system and the other area continues to work, maybe not as good as normal, then you lead to a lack of resorption, for instance, of microfractures, microcracks in the bone. They're occurring all the time in our skeleton. So we still don't understand very well how these medications work. One thing that I always question my colleagues endocrinologists is, okay, the inhibition of osteoclasts prevent the bone from remodeling, but you have increased in the bone density. But what is the quality of that bone? And we see with the fracture of the femur, where you have a very brittle bone formation. So it's not the same quality of bone that is being formed. The bone looks denser in the test, but it doesn't have the same flexibility that the normal bone has. So we're still considering all of these things. And right now we're doing adjudication of cases for the trials with romosozumab. And we have to follow cases where there is suspicion of osteonecrosis of the jaw with a medication that now is supposed to form bone, not to stop the remodeling.
Another one, Gustavo Rabelo, thanks for the lecture. I have a question. I think that's in part you answered this question. How about microcracks and targeting for bone remodeling? Do you think that this should be linked to the etiology of MRONJ?
Yes, it is. It is linked, and I just mentioned it. But we believe that we know the bone remodeling occurs all the time, okay? And we know that there are histological fractures, microfractures and cracks of the bone that need to be eliminated by the osteoclasts. But because osteoclasts are inhibited by the medication, then you don't have that bone that is now defective being removed. So we believe that that accumulation facilitates, for instance, the presence of bacteria in these areas that can find a niche there and start the process of infection of the bone. So we believe that the microcracks and microfractures are a very important factor in the formation of osteonecrosis of the jaw.
Another question from Vivian Peterson Wagner. Do you currently know if there are important differences between the pathogenesis of the resorptive associated osteonecrosis of jaws and anti-angiogenic associated osteonecrosis? And if yes, does these different pathogenic mechanisms have any impact in current therapy or could influence future target therapies?
Okay. Well, if you read the letter to the editor that I sent to the Journal of Clinical Oncology, at that time we felt that there was a tremendous effect on the blood vessels, and that we called osteonecrosis due to poor circulation. Okay? And we knew from studies done in animals that bisphosphonates would produce anti-angiogenesis. Later on, we learned that the dose of medications that were needed to produce anti-angiogenesis was very, very high, much higher than what was being used in the adults. So then we kind of forgot about the blood vessel part of the modeling and start to think about the effects of the medications in bone directly with the osteoblast modeling. But then, with the advent of the anti-angiogenic medications and the large utilization of these drugs, we started to see cases of patients taking only anti-angiogenics and developing osteonecrosis. They were not taking any of the anti-resorptives. So the anti-angiogenics, by preventing the formation of bone vessels and vascularization of the bone, can also lead to the formation of bone necrosis. Now we know from studies, especially people with renal malignancies, have bisphosphonates associated with anti-angiogenics, and that association increases the risk of them developing osteonecrosis very, very largely. So it's almost over 10% chance as opposed to 1 or 2%. And so it shows the importance of the additive mechanisms of the two drugs increasing the risk for the formation of osteonecrosis of the jaw. So therefore, both drugs, both mechanisms have an influence in the process. And I don't know of any drugs that will oppose to that. As I commented before, there is nothing being studied right now specifically to treat osteonecrosis of the jaw with medication specifically for the mechanisms that we believe are acting up. Confusing?
No. A question from Liam Robinson from South Africa. Professor, what is your experience of post-treatment changes with denosumab for giant cell lesions of the bone, mimicking an osteosarcoma on histological assessment?
I don't have experience. He is probably a pathologist. The type of question is coming from a pathologist. I don't have much experience. I can review the trials with giant cell lesions, but I don't remember specifically reports of osteosarcoma as the post-therapy. So again, if you have any literature on that, please correspond with me, send me an email, and I'll be happy to read the literature and discuss with you. I can also contact my oral pathologist at the University of Florida and then find from them if they have any experience. Do you, Manuela, have you seen cases?
No, I don't have experience with these cases.
Yeah, we still don't have much follow-up time because the trials finished not too long ago. So the post-operatory or the post-treatment phase is still being under investigation, and Amgen has to do that follow-up based on the requirements that they have from the Food and Drug Administration. So we may still see new information come up along that line. But please send me an email with the information. I'll be happy to discuss with you.
Perfect. Another question from Bruna Barcelos Só, my students here at URGS, regarding the stage of osteonecrosis. Will a patient with stage 0 necessarily develop a more advanced stage if not treated? If not, which factors related to the patient influence a patient having a stage 0, or a 3?
Well, I wish I could answer that question.
Magic ball.
The fact that you have a lesion stage 0 doesn't mean that you have a small lesion. The Italians have shown this, that you can have a patient where you cannot find any exposed bone clinically visibly, but they show extensive areas of bone necrosis by using imaging. And then when they treat the patient surgically, they realize how big the defect is, and they couldn't see anything clinically. That's why the Italians are strongly against this stage 0 definition from the Americans, because they find patients who are in that situation, what you could call a stage 3, because of the extent of the lesion, risk of fracture, and so on. So we still don't know why the stage 0 does not open the mucosa and shows the exposed necrotic bone. So it's still under investigation, and the controversy is still there. Who has the right answer? So I don't know if I was able to answer your question completely, but it's still in a lot of discussion.
Ivan Neto, does the treatment for MRONJ due to denosumab and antiogenics follow the same approach? Thank you, Professor Migliorati. Excellent lecture.
Yes, thank you for the question. The treatment does not change because of the drug the patient is taking. The treatment is done the same way. And again, it depends on the type of patient you're seeing, the type of disease that you're seeing, why the medication is being prescribed. So all of these things influence in your decision making in the clinics and how you're going to treat the patient. Okay, so there is no modification that you have to do if a patient is using an anti-angiogenic and has developed osteonecrosis, or if the patient is using denosumab and developed osteonecrosis of the jaw. We treat the patients the same way.
Perfect. Cynthia Milani, amazing lecture, Professor Migliorati. How long after the cessation of the intravenous medication would you say it's safe for dental alveolar surgery with no risk of MRONJ?
Well, again, the medication giving IV does not incorporate in bone, in the bone matrix. If you think about Zometa is giving once every 4 months IV infusion. Okay, if you think about the denosumab, is also giving once a month, and so the reason being is that in order to maintain a therapeutic level of the drug has to be given constantly. Okay, so we assume that after a month there will be not much medication left. Okay, because you need to give another challenge to the system. If you think about the patient with osteoporosis, they may take Prolia only every 6 months, a very small dose, or they can take Reclast once a year. So for the osteoporosis disease, you don't need as much medication. The dose is not that much. So I would say, if you're thinking about the denosumab, After a couple of months from finishing treatment, I would say the patient should be okay to treat. The same thing may be with Zomita, that is IV infused. But if it's a medication given per oral, the thing is different, okay? Like alendronate and pamidronate, those are medications the patients take once a week. So again, I think if my patient comes in with a history that, well, I was under this treatment for until 3 months ago, and I'm okay now, I'm no longer taking it, and I need treatment, I would say that I would feel more comfortable treating the patient now than if the patient was still getting the medication at the regular basis doses.
Question from Leticia Lang. We use photodynamic therapy to manage infections with great results on MRONJ. Do your group use this therapy? Thank you for the amazing lecture.
Thank you for the question. I particularly do not use the light therapy for the osteonecrosis. I have been away from the clinic due to my duties at the university, but I have been collaborating with groups. Manuela and her group had a paper that I was a co-author, and they use laser light. I also worked with Marcia Marquez and other colleagues who were doing surgery and then stimulating the healing with the laser light, and people who have good results. I know of the effects of photodynamic therapy to control infections. So again, I don't have personal experience, but I read the literature and I see that people have good results. And I'm going to say the same thing I said before. If you're working a technique that is giving you good results, it's helping the patients keep using it.
Another question from Vivian. I have one more question. Do you believe future guidelines for MRONJ might exclude the requirement of exposed bone in the diagnosis criteria? Some patients with non-exposed bone could benefit from preventive methods and closer follow-up, and maybe including them in the diagnostic group could have some benefits. What is your opinion?
Yeah, my opinion is that I believe that this is the way we're gonna do for the future. We work in guidelines with the American Society of Clinical Oncology. It was published in the Journal of Clinical Oncology about a year ago, I think. And there was a lot of discussion about the stage 0, and if we could diagnose patients at that stage and treat immediately. And there is always a controversy. Do you treat surgically or do you use medication? What is the best approach? So we're still learning, but I believe that soon that stage 0 will be removed from the staging system. And with the American Society of Clinical Oncology on board and supporting our guidelines, there are lots of people, physicians who treat cancer patients and involved in this. So it is no longer a decision only from the dental people. There is a large universe of colleagues working with guidelines. I wanted just to emphasize that writing guidelines depend on the information that you have available in the literature. So in order to state something, pardon me, you must have evidence. To give an idea, to write a guideline with ASCO, we had a committee with about 25 people. We had to have at least 75% agreement on a statement. If we didn't have science, okay, it would be expert opinion. So if we did not have 75% in agreement, we would not call it a guideline. We would say guideline not possible. So it is very tricky to write guidelines, but I think specifically about the stage 0 discussion, there will be a lot of work coming up pretty soon.
Perfect. Question from Paulo Moraes. Excellent talk. I recently read an article about 2 cases of necrosis by simvastatin. Does this proceed? Do you have an experience?
Hi, Paulo. Good to hear from you. I have not read this, Paulo, but if you send it to me, the reference, I will read it and then we can communicate by email. I have not seen this. With the pandemic of COVID, my life turned upside down. It's been very difficult to do science, go back to the normal academic job. So I haven't been reading much the literature recently, and I missed this. I haven't seen this.
Perfect. From Professor Elismauro Mendonça, excellent lectures, Cesar. My question is, although there are several papers about osteonecrosis of the jaws, why this information did not reach the oncological patients and medical oncological team, especially in Brazil?
Well, hi, Elismauro. I saw you in the previous lecture. You're looking good. Thank you for attending this presentation. So, you know, I think I comment on a paper that we wrote together with a group from the Northwestern University, where they were following the FDA for for complications in general from different medical drugs. And we wrote one specifically about osteonecrosis of the jaw. And when this group approached the FDA had received already over 300 reports of this complication, and they had done nothing. Then, if it wasn't for the work of people like me and other colleagues who started to write reports and publish, the drug industry would not have acted up as much as they had to do if it wasn't for our efforts in making this known to the medical and the dental community. In Brazil specifically, I have lectured in Brazil. I was working in Brazil when we first saw cases like this. I have been in contact with oncologists in Brazil. I think there are no specific explanations about why this complication is not considered seriously by those prescribing the medications, especially for cancer patients when the risk is higher. I really don't have an answer. Everything that I could do in terms of publishing, in terms of lecturing, not just me, so many of you have published in the Brazilian literature, international literature about this complication. There are so many people now working at the hospital setting in Brazil, so much more than here in the United States. So I think it has to do with the lack of communication. We just have to communicate a little better with our physicians colleagues. But more than that, I don't know what to tell you.
Now a question from a special person, Professor Abel Silva Cardoso, our great Professor Abel. Excellent lecture. Congratulations, Cesar. Do you have an experience with therapeutic therapartide in the management of refractory cases?
Hi, Abel. Good to hear from you. Hope you're doing well. I personally have not prescribed the teriparatide to patients. I have read reports. I have not seen a study that is randomized, controlled. The reports are anecdotal, and the reports I have seen, people claim that the teriparatide was what led to the healing of the lesion. But then when you read the history, patients were on one of the anti-resorptive medications previously and had discontinued the medication some time ago. Okay, so the reports that I am familiar with are anecdotal, and there is no scientific studies that show that if you prescribe only teriparatide, you will obtain the healing of the lesions. And there are limitations in the time that you can use the teriparatide for your patients. Also, the price is very, very high here in the United States. So I personally do not have experience.
Thank you, Cesar. And I would like to thank you, Professor Abel, for all the support that you have been giving to us in SOBEP. Thank you so much, Professor.
We go back so many years that we're not going to go there.
From Professor Mário Romanach, Rio de Janeiro. Thanks, Cesar. Could you comment about the pseudoepitheliomatous epithelial hyperplasia of odontogenic origin microscopically observed in association of some cases of MRONJ? All the best from Rio.
Thank you. Thank you, Mario. I personally don't have experience about the histopathology, and I would like to get some references that I can discuss with my colleagues, pathologists. I have not seen these cases yet. So if you have cases, I would appreciate you sending me literature. And Manuela, do you have any experience in this?
I have seen before, but not so much, because sometimes we just receive the bone that was removed, and we don't receive a lot of connective tissue and epithelial tissue around. But I think that is very good to look these aspects.
Maybe in cases they're removed surgically, that you have a resection, I think then you may see other changes, as opposed to just curettage, where you get a bunch of bone and bacteria. But I don't have any personal experience, and I would like to get information on it.
We have 3 more questions. Leticia Lang, Professor Ruggiero told about some genetic tests to patients to prevent osteonecrosis of the jaw risk. Is that some progress on these studies?
I'm not familiar with that. That was when Sal was in Brazil last year. When was it?
I don't know.
He was in Brazil recently, but
I don't know.
I don't know of any genetic predisposition. There have been studies showing some polymorphisms, but there is nothing that is solid. I remember finding a high prevalence in people from the Mediterranean area, lots of cases in Greece and Italy and Israel. And so we suspect that there may be some kind of genetic predisposition, but we still do not have a test that is specific to show this.
Perfect. The other question is from Luis Gueiros, our good friend. Thanks, Professor, amazing lecture. A recent paper on JCO showed promising results with teriparatide from the management of the oncological patients MRONJ. Even though the results are promising, oncologic safety was not included as a secondary endpoint. Can we consider as an adequate options to further trials, or should we consider eventual oncological risk more carefully?
Well, I think if you have that evidence from JCO, those papers are really solid and robust. And if you want to try teriparatide, I would say go for it, but make sure that you do it together with the medical people. I don't like to prescribe medications that are a little out of our scope of practice. I try to work together with the physicians, and then we do the oral follow-up. But if this paper is showing that evidence, I would say if you want to try, there's again nothing wrong.
Perfect.
Good
We have
to hear from you, Luis.
We have another question, but it's similar from Bruno Freitas, but it's similar. Now, Bruno Maris, thank you for our beautiful talk, Dr. Migliorati. What advice would you give to future clinical researchers in order to significantly improve our knowledge on how to treat these patients?
Okay, well, I think it is my way of doing things, working with the teams of colleagues. I don't like to work alone. I think when we have a team, we have so many more brains together thinking about the best ways to practice. And so the first thing that I would recommend is to have a team of people who are interested, who observe things well, who have experience or are acquiring experience, and then formulate modelings that you can follow as much as you can based on evidence in the literature, but then you build on top of your own experience as you treat the patients. You observe. And this is kind of the message that I am trying to give with this lecture, that everything started with an observation of a patient who was referred to me, who had something that I thought that was easy to resolve, and it didn't respond the way I expected. When I talked to my friends, my colleagues in oncology, they said, oh, this is easy. We just stop the medication and it should go away. And it didn't go away. So now what you do, okay, so you keep observing, you keep trying, you take history, you discuss with your colleagues, share experience, and then you move on, okay? But I firmly believe that there is a plus when you have a team of colleagues working together. And that's my main advice to the young researchers. So right now, there is a new thing happening. There are so many biologicals being used for all kinds of diseases, monoclonal antibodies and so on. And we're seeing so many new oral manifestations of the biologicals. They resemble all kinds of things, lichen planus, pemphigoid, pemphigus, erythema multiforme. And so there's almost every week there is a new drug being tested, and oral cavity is never part of the clinical trials when they're studying these drugs. So it's up to us, the dental people, to follow the patients. And every time you see something new that your patient is being given and you're not familiar with, go find out what it is, what it does, and then follow the patient closely. We're seeing now the COVID patients, COVID-19 infected patients with all kinds of oral lesions. Okay, so all of this is new, it's coming, affecting the oral cavity, and it's up to us to observe, diagnose, and manage.
What a such good experience that you have. Excellent, excellent advices. And during your talk, you gave us an important lesson, Cesar. You said that you are a specialist with more questions than answers. This shows us who you are. You are really, really special. Yes. Thank you, Cesar, again. Congratulations for being nominated for the Samuel Charles Miller Award of the American Academy of Oral Medicine. Thank you for all that you have been doing for us, for our community, for our society, for the people, for the patients. And we are very, very honored to have you here in this closing lecture of our first online meeting. Thank you so much for sharing your experience, your knowledge, your all your smile, your intention to be good. This is what we need in this time of this difficult time. So it's very important to share knowledge, but also share the good vibration. And when we see you, we can observe this, the feeling that it's good to do our job, that is good to follow the patient, that is good to try to understand the disease. So you are a very important inspiration for all of us. I hope that you and Erica could be here with us next year in Bento Gonçalves. You both are amazing friends, and we admire you so much. Thank you again. Thank you for all the people that attend to our meeting, and especially in this moment. Thank you, Cesar, for all the things.
Thank you so much, and I'm sorry that I cannot be there in person to see all of your smiling faces, old friends, new friends. I miss you so much, but this is the road that my life took, but I never lost the contact with you. It's a pleasure always to participate and collaborate in any way I can. And I hope that this will continue for many more years to come. Thank you all. Of course. Stay safe. Don't forget to wash your hands.
Use mask.
Use the face mask. Those are two very important things.
Yes. Now in Portuguese. Pessoal, nós vamos então fazer um stop de poucos minutos. Pedimos que vocês continuem conosco, porque nós vamos fazer o sorteio, algumas palavras finais, o encerramento do nosso evento, e depois nós temos um pequeno encerramento com um pouco de música para alegrar a vida de todos nós e finalizar esse primeiro encontro. Muito obrigada, Cesar, mais uma vez. E esperamos...
Obrigado a vocês.
E esperamos que você e a Érica curtam também essas nossas músicas de encerramento. Dancem um pouquinho, divirtam-se também. Muito, muito obrigada. Um beijo grande.
Beijo. Tchau.
Tchau.